Hello and welcome to this FERNE presentation. We will be discussing today seizure and status epilepticus patient guidelines, presenting a simple clinical pathway. My name is Edward Sloan. I'm an emergency physician in Chicago. This information was most recently presented at the 10th World Congress in Emergency Medicine in November of 2022. I'm Professor Emeritus at the Department of Emergency Medicine at the University of Illinois at Chicago in Chicago, Illinois, and I'm Medical Director for the Physician Assistant Studies Program at Dominican University in River Forest, Illinois. I serve as the Medical Director for New Rose Healthcare Management at Roseland Community Hospital, a safety net hospital in Chicago, Illinois. My thanks to the 10th World Congress and mi amigo Carlos Garcia Rosas. He is a great man and a force in emergency medicine, and thank you, all of you who are watching and participating in this educational endeavor. I have no financial conflicts. I serve as the FERNE President and Board Chair, FERNE, the Foundation for Education and Research in Neurological Emergencies, FERNE.org. More about FERNE later. Background to our discussion of the management of patients with seizures and status epilepticus. In 1994, in JAMA, the Epilepsy Foundation of America provided treatment of status epilepticus guidelines. 22 years later, in 2016, the EFA guidelines are revised for the first time. And then today's presentation will discuss the following: the 2016 American Epilepsy Society guidelines, the 2014 ACEP Clinical Policy, and the 2020 AES Treatment of Refractory Convulsive Status Epilepticus monograph. So our learning objectives. We will review the American Epilepsy Society guideline for the treatment of convulsive status epilepticus. We will understand and discuss the ACEP Clinical Policy for ED seizure patient management, and we will update our status epilepticus treatment based on the AES Treatment Convulsive Status Epilepticus publication. An environmental assessment. In the medical literature, there are actually relatively limited number of relevant clinical trials that guide our treatment of patients with status epilepticus. There are few valid clinical trials establishing clinical efficacy of one specific anti-epileptic drug over another. Case series do exist that give us some guidance, and our clinical policies provide for us options as treating physicians. Regarding guidelines, there actually are few US or EU guidelines. The AES or EFA guideline has been the industry standard for status epilepticus treatment as a protocol for decades. The AES treatment of convulsive status epilepticus addressed in 2016 and 2020 are optimal treatment strategies, and the ACEP Clinical Policy addresses specific questions related to seizure and status epilepticus patient management and was last revised in 2014. Let's begin with the 2016 AES Status Epilepticus Guideline. This guideline by Glauser and a staff of committee persons provides us an evidence-based guideline for the treatment of patients with convulsive status epilepticus, both in children and adults. This proposed algorithm is provided here in a summary graphic, and from this we know the interventions are designed for the emergency department, the inpatient setting, the pre-hospital setting with trained paramedics. This graphic comes from Glauser's evidence-based guideline. It includes 4 time periods, and the key concept that drives each of these subsequent time periods is whether or not the seizure or status epilepticus persists. The initial care is consensus-based. The initial therapy is always with benzodiazepines. The second therapies, if required, are up to the provider choice. And the third line therapies are also choice-based and are related to what's available in the system in which a particular provider practices. This again is the graphical representation of the flow diagram or algorithm for the treatment of patients with seizures and status from the Glauser Clinical Guideline. So again, our clinical setting. These interventions are designed to be implemented in the emergency department in an inpatient setting such as a hospital or in the pre-hospital setting with trained paramedics. The first part of the timeline involves a stabilization phase thought to be optimized during the first 5 minutes of treatment. What's involved with that stabilization phase? First, the patient needs to be stabilized. Airway, breathing, circulation, disability, including a brief neurological exam. Then, it's important that the seizure be timed from its onset during this initial management and monitor the vital signs as the ongoing therapies are provided. Next, assess oxygenation, give oxygen via nasal cannula or mask, and then consider intubation if respiratory assistance is required in order to assure adequate ventilation and oxygenation. Next, ECG monitoring is recommended. Next, a fingerstick blood glucose should be determined. If the glucose is less than 60 milligram percent, then in adults, 100 milligrams thiamine IV and 50 milligrams of D50W is provided IV. In children greater or equal to 2 years of age, 2 milligrams per kilo of D25W IV, and in children less than 2 years of age, 4 milliliters per kilo of D12.5W is provided IV. Lastly, attempting an IV is critical in order to collect labs for electrolytes, hematology, toxicology screening when appropriate, and anticonvulsant levels if clinically indicated. If following the first 0 to 5 minutes of patient stabilization, which understandably could take longer than 5 minutes, if the seizure continues, then the protocol suggests that the provider should continue to the initial therapy phase for the treatment of patients with ongoing seizures and status epilepticus. The timeline for this phase is 5 to 20 minutes. This initial therapy phase then should take approximately 15 minutes overall. We know that a benzodiazepine is the initial therapy of choice. There's level A support that suggests always when treating with an anti-epileptic drug, the first therapy should be a benzodiazepine. And there are 3 options, each thought to be equivalent in their ability to treat a patient with seizures or ongoing status epilepticus. The first is intramuscular midazolam. An initial dose could be 10 milligrams for any patient greater than 40 kilograms IM, and for children 13 to 40 kilograms, a 5 milligram IM dose in a single dose is recommended. There's level A support for this recommendation. A second benzodiazepine option is intravenous lorazepam when IV access is available. The dosing is 0.1 milligram per kilo per dose, a maximum of 4 milligrams per dose, suggesting that the dose could be repeated 1 time. There is level A support for this in this particular guideline. The third option is intravenous diazepam at a 0.15 to 0.2 milligram per kilo dose, a maximum of 10 milligrams per dose, suggesting that it could be repeated times 1 with level A support. If none of these 3 options are available, IM midazolam or IV lorazepam or IV diazepam, there are other options that are available during this initial therapy phase, understanding that the benzodiazepine is always preferred. But if those are not available for any reason, intravenous phenobarbital can be given 15 milligrams per kilo per dose as a single dose with level A support, or rectal diazepam 0.2 to 0.5 milligrams per kilo, maximum of a 20 milligram dose as a single dose with level B support, or intranasal midazolam or buccal midazolam both with level B support. If at the end of this 5 to 20 minute phase, which understandably could take a short amount of time longer, if the seizure and status epilepticus persists, then it's important to continue to the second therapy phase. The second therapy phase is intended to occur between 20 and 40 minutes. When discussing medications, anti-epilepticus drugs that can be provided during this second therapy phase, there is no evidence-based preferred second therapy of choice, so the level of support is undetermined. So, since there is no preferred second-line medication to be provided, any one of these can be chosen and given as a single dose. The first is the option to give intravenous fosphenytoin at 20 milligrams of phenytoin equivalents per kilo. The maximum dose is 1,500 milligrams PE per dose, again without support that this is superior to other therapies. If fosphenytoin is not available or preferred for some reason, the next option would be intravenous valproic acid or valproate, 40 milligrams per kilo, maximum dose 3,000 milligrams per dose with level B support, or intravenous levetiracetam, 60 milligrams per kilo, maximum dose 4,500 milligrams per dose with level U support, again suggesting this is not known to be superior to other second therapy medications. Now, if none of the above options that we mentioned are available, that would be fosphenytoin or levetiracetam or valproate, then there is an option to give intravenous phenobarbital, again 15 milligrams per kilo, maximum dose, with level B support for its efficacy for ongoing status epilepticus. At the end of this 20-minute period, which understandably could take a short amount of time longer, if the seizure continues, then it's important to continue to the third phase of treatment. The timeline for this third phase is approximately 40 to 60 minutes, a 20-minute period during the third phase of medications. As with the second phase of anti-epileptic drug therapies, there's no clear evidence to guide any single therapy as being superior to another, so the level of support still remains undetermined. The choices include repeating whatever second-line therapy was provided in an additional dose, or to provide anesthetic doses of thiopental, midazolam, pentobarbital, or propofol, understanding that if any of these third phase medications are provided, it's necessary to provide continuous EEG monitoring, because with these medications, patients will be unresponsive. It will be impossible to determine whether or not there's subtle status epilepticus ongoing, which is ongoing brain seizure activity without any motor manifestations that are noted clinically. On this slide, which again summarizes the clinical guideline from AES by Glauser et al., we can see that over a 60-minute period, it is intended that optimally a patient during the first 5 minutes can be stabilized. If seizures continue during the next 15 minutes, initial therapy with any benzodiazepine options is suggested. During a 20-minute second therapy phase, additional medications can be given based on the ability of any individual institution and provider to give this therapy. And during the last 20 minutes would be a third phase of anti-epileptic drug therapy for patients who have ongoing seizure and status epilepticus. It is understood that it is a 60-minute time period during which optimally the status epilepticus is terminated, because it is known that beyond 60 minutes, the mortality from status epilepticus is quite high, and that's either related to the seizure itself or the cause of the seizure, which may carry with it a high morbidity and mortality. Again, this is a graphic of the proposed algorithm from the Glauser Epilepsy Currents publication in 2016. And from this, we know that it's applicable to most all settings where they're trained providers. We know that the evidence in the guideline is for the most part not strong, except to say that benzodiazepine should be the initial therapy of choice. We know there are 4 time periods, and it's important to start the stopwatch the minute the patient arrives or begins to have the status epilepticus episode in whatever clinical setting. We know that subtle status epilepticus is a concern, and that if you get to the 3rd phase of treatment, it's necessary to provide ongoing EEG monitoring to exclude subtle status epilepticus. We know that the initial care is consensus-based, that is to say, the initial resuscitation is similar to the resuscitation of all patients who present in extremis, whether or not it's related to status epilepticus. We know that our initial therapy is related to the benzodiazepines and that lorazepam is the preferred IV medication when available. We know that the second-line therapies, when indicated and necessary, require medications that should be available either in the emergency department or whatever critical care setting in which status epilepticus might need to be treated. And we know that once third-line therapies are provided, that ongoing EEG monitoring is necessary to exclude subtle status epilepticus. That ends our discussion of the 2016 AES Clinical Guideline for the treatment of children and adults with status epilepticus, ongoing seizures. We now will discuss the 2014 American College of Emergency Physicians, ACEP, Emergency Department Seizure Patient Clinical Policy. This policy, which was published in 2014, was developed by members of the Clinical Policy Committee of the American College of Emergency Physicians. The authors are listed here. This is a summary slide which simply goes through what are the clinical questions that were addressed by the clinical policy. It's understood that many of the clinical questions that are addressed don't have clear answers, hence the necessity to come up with a clinical policy that can help to arbitrate what is in the medical literature so that providers understand what are their options in treating patients who present with seizures and status epilepticus. So the first clinical question has to do with how patients with first-time seizures should be treated. The question is as follows. In patients with a first generalized convulsive seizure who have returned to their baseline clinical status, should antiepileptic therapy be initiated in the emergency department to prevent additional seizures? The patient management recommendations. There are no level A recommendations and there are no level B recommendations because there is not concrete, clear evidence that would support either of these stronger recommendations. There is a level C recommendation that is as follows. Part 1. Emergency physicians need not initiate antiepileptic medication in the ED for patients who have had a first provoked seizure. Precipitating medical conditions should be identified and treated. The second level C recommendation for this question is that emergency physicians need not initiate antiepileptic medication in the ED for patients who have a first unprovoked seizure without evidence of brain disease or injury. In this case, a provoked seizure would indicate a seizure that could be related to some event such as head trauma. An unprovoked seizure is meant to be a seizure that occurs without any clear provoking medical illness or injury. And again, an initial AED or antiepileptic drug need not be initiated if there's no evidence of brain disease or injury at the time of evaluation. The third part of the level C recommendations related to this clinical question of how to treat patients with an initial seizure states that emergency physicians may initiate anti-epileptic medications in the emergency department or defer this medication initiation in coordination with other providers such as an epileptologist or neurologist for patients who experienced a first unprovoked seizure but who have a remote history of brain disease or injury. In other words, with a known past brain injury or illness related to hemorrhage, for example, it may be preferred that a patient be started on an anti-epileptic medication, especially if a patient is involved with a high-risk occupation, such as a person who's working building a building and may be located several stories above the ground. In this case, it may be decided that an initial anti-epileptic drug be initiated in the emergency department for these patients. The second clinical question addressed by the ACEP 2014 Clinical Policy has to do with patients who have a first-time seizure in whom admission might be considered. The question is as follows. In patients with an unprovoked first seizure who have returned to their baseline clinical status in the emergency department, should the patient be admitted to the hospital to prevent future adverse events? As with our first clinical question, there is not sufficient support for a level A recommendation or a level B recommendation to address this clinical question. There are, however, clinical support items that would support a level C recommendation. And it reads as follows. Emergency physicians need not admit patients with a first unprovoked seizure who have returned to their clinical baseline in the emergency department. In other words, unprovoked seizure, patient returns to a normal clinical baseline in the emergency department, there's no need to admit these patients. The third question, addressed by the ACEP 2014 Clinical Policy, has to do with how seizure medication should be provided in the ED. The question reads, in patients with a known seizure disorder in which resuming their anti-epileptic medication in the ED is deemed appropriate, does the route of administration impact the recurrence of seizures? In other words, does it matter which route is utilized in preventing subsequent or recurrent seizures from occurring? As with our first two questions, there's insufficient strong evidence that would support a level A or level B recommendation for these guidelines and to answer this clinical question. There is a level C recommendation that states when resuming anti-epileptic medication in the ED, if it's deemed appropriate, the emergency physician may administer IV or oral medications at their discretion. In other words, it does not matter whether an anti-epileptic drug is provided IV or orally following a first unprovoked seizure, in that either way, the rate of subsequent seizures is the same. It is not necessary to give drugs or medications through the IV route in order to prevent a greater likelihood of a subsequent seizure. The fourth clinical question, addressed by the ACEP 2014 Clinical Policy, is as follows. In ED patients with generalized convulsive status epilepticus who continue to have seizures despite receiving optimal dosing of a benzodiazepine, which agent or agents should be administered next in order to terminate the ongoing seizure and status epilepticus? In other words, following the initial therapy with benzodiazepines, is there a second therapy drug that is preferred one over the other? In this case, there is support for a level A recommendation, which is the strongest recommendation, that states emergency physicians should administer an additional anti-epileptic medication in emergency department patients with refractory status epilepticus who have failed treatment with benzodiazepines. In other words, if the benzodiazepine therapies do not terminate the seizures and status epilepticus, a subsequent medication in a second therapy phase should be provided. A level B recommendation with less strong clinical support data states that emergency physicians may administer intravenous phenytoin, fosphenytoin, or valproate in emergency department patients with refractory status epilepticus who have failed treatment with benzodiazepines. We know from subsequent data that was published since 2014 that IV levetiracetam also is an option in this second phase, but it was not documented and a part of this 2014 clinical policy. Levetiracetam and other therapies were identified in a level C recommendation stating emergency physicians may administer intravenous levetiracetam, propofol, or barbiturates in ED patients with refractory status epilepticus who have failed treatment with benzodiazepines. In other words, as second phase therapy, although it is not proven that any one of these is superior to the others or the ones listed in the level B recommendations, we know that levetiracetam, propofol, or barbiturates can be given by IV infusion into ED patients with ongoing refractory status epilepticus. This slide again demonstrates the 4 clinical questions with the recommendations based on the strength of evidence that supports these clinical recommendations. So these are 4 important clinical questions that were identified and provided by the ACEP Clinical Policy in the 2014 publication. In this 2014 ACEP Clinical Policy, there is an anti-epileptic drug table that provides interventions for emergency department use. It includes medications, their doses and infusion rates, as well as adverse events that could be expected. This is a good table that identifies commonly used medications for the treatment of emergency department patients who present with seizures and status epilepticus. The 2020 AES Treatment Committee treatments for refractory convulsive status epilepticus have subsequently helped us to better understand what medications might be used in a third phase of therapies for patients with ongoing seizures and status epilepticus that has now become refractory. This is a publication by Vossler regarding a comprehensive review by the AES Treatments Committee. From this publication, we know it was a structured literature search. The intent was to identify which medications will optimally stop convulsive refractory status epilepticus, knowing that no clear single medication has been identified or established to be superior. We know that convulsive status epilepticus that is not refractory may benefit from fosphenytoin, levetiracetam, and or valproate infusions, all that are viewed to be equally effective. We know that whether or not this same statement is true for convulsive refractory status epilepticus is unknown. And the publication does identify that more convulsive status epilepticus clinical trials are needed. So when considering this convulsive refractory status epilepticus publication, the following are noted: brivaracetam, lacosamide, levetiracetam, valproate, ketamine, midazolam, pentobarbital, and propofol are all supported with limited data in the termination of convulsive refractory status epilepticus. In other words, no single medication has found to be superior to the others for the treatment of convulsive refractory status epilepticus. ACTH, IVIG, corticosteroids, magnesium sulfate, pyridoxine, all have only been used in limited circumstances and do not have clinical data that would suggest their superiority to any other medications. And again, this publication suggests that controlled clinical trials are needed to study the anti-epileptic drugs and anesthetizing agents that could optimally treat refractory convulsive status epilepticus. In this 2020 AES publication, there is a medication table. It includes standard and exceptional meds, that is, meds that are routinely used and those that might only be used in exceptional circumstances. It includes loading doses and maintenance doses. It includes what are appropriate serum levels, if applicable. It identifies serum half-lives when known, and it addresses special considerations such as unique populations, pediatric versus adult, and or what adverse events occur. This is the table from the 2020 AES publication that provides the information that was identified when discussing the previous slide. So in conclusion, when we are discussing the treatment of patients with seizures and status epilepticus in the emergency department, pre-hospital setting, or critical care areas of the hospital, we conclude the following. A new AES guideline was published 22 years later after the initial EFA status epilepticus guideline was published. The AES guideline, published in 2016, uses a three-phase approach to the treatment of seizures and status epilepticus. We know that the ACEP 2014 Clinical Policy does provide treatment strategies for relevant clinical questions. 4 questions were addressed, and guidelines and recommendations given based on the strength of evidence in the medical literature. We know that similar options for the treatment of status epilepticus are provided in the ACEP Clinical Policy and in the AES 2016 guideline. We know that information in the 2020 AES publication confirms that there is a great deal of uncertainty regarding the optimal status epilepticus therapy, but it does identify similar best options for consideration for patients with ongoing refractory status epilepticus. Recommendations. So from our analysis of guidelines and clinical policies that address the care of patients with seizures and status epilepticus, we have the following recommendations. It's important to know these guidelines: the 2016 AES guidelines, the 2014 ACEP Clinical Policy questions, and the 2020 refractory status epilepticus medication recommendations. It's important that the care that is provided to patients with seizures and status epilepticus be timed. That is, the minute a patient presents to the ED with convulsive status epilepticus, and or if a seizure begins in the hospital or other critical care areas, it's important to start the stopwatch and begin to follow how much time it takes, knowing that the stabilization phase and the 3 treatment phases optimally should all occur within the first 60 minutes of the onset of the seizure. We know that if guidelines and clinical policies are followed, it is possible to improve the outcomes of patients based on the use of a protocol. Because the second and third phases of treatment have no single supported preferred medication, we know then it's important to develop a protocol for your own individual emergency department or clinical care areas based on what medications are optimally utilized within your institution. In other words, the first phase that includes benzodiazepines, those benzodiazepines should be available in the clinical areas. Following that, it should be important to have at least 1 second therapy medication available and 1 third phase medication available for the treatment of patients with ongoing seizures and status epilepticus. How do you make that selection? You select which agents could be used based on their optimal use within your institution and use them in rapid succession at optimal doses. That is to say, While one medication is being provided, another medication should be prepared so that it can be given immediately following the termination of the first initial anti-epileptic drug therapy. We know that because fosphenytoin, levetiracetam, and valproate are most likely to successfully treat status epilepticus, these medications should be the focus of subsequent use following the initial treatment phase with benzodiazepines. Thank you for taking the time to learn more about the treatment of patients with seizures and status epilepticus. For more information, please go to the FERNE.org website, and also please subscribe to the @FERNE.org YouTube channel. We encourage you to go to all of our social media sites to obtain or to learn what are the most current optimal therapies for the treatment of patients with any neurological illnesses, injuries, and/or emergencies. FERNE.org. If you have any comments or questions, don't hesitate to email us at fern.org@gmail.com. I'd like to thank you, and Ken Moore, listed here on the left, also thanks you for your time and efforts on behalf of patients with emergency illnesses and injuries related to neurological diseases. Once again, Edward Sloan, thank you.